Okay, perhaps we should begin. Good afternoon to all of you. Our workshop is titled with digitalization as an important factor to ease the access to services of general interest, the case of e-health. And I would like to ask you to switch down the sound. And so perhaps you can give us your pictures, and so I think we can begin. I would like to give a short input to the topic of e-health, and then we will hear Hannah Bock-Koltschin with a report, and Mauro Grigioni also with a report, and Marco Bazzani, he will be the last reporter to our topic. I give a screen. Okay, I hope you can see the screen. Is this right? Yeah?
Yes.
Okay,
it is.
Wonderful. Okay, so first of all, I would like to give you a short input to the topic. What are the approaches to the semi-digital and digital healthcare from the perspective of the baby boomer generation? The baby boomers are the generation born between 1955 and 1965 or 70. This generation who is coming now to the retirement, and the generation who perhaps needs the most health services in digital health. The access to my report is, first of all, the equivalent living conditions. The second one is the demography. The third one is supply of rural areas. And the fourth one is new challenges posed by the pandemic. The services of general interest have a broad spectrum, and the digitalization is one of the accesses. The yellow marked points are the services of social services, retail and education, water and energy supply, waste, public and private, local and long distance transport, postal and telecommunications, social services and health and medical services, and recreational facilities, community services. First of all, the demography. The demography is one of the most important accesses. We're aging in Europe. Mostly all countries are aging. We have a small increase of younger population groups due to an increase in births. We have immigration, where young people are emigrating the rural areas, and we have a decrease in net migration in all groups, in all age groups. Another access is the question of pandemic. We know about the importance of decentralized structures. For example, hospitals, small houses as reserve supply, as small hospitals. We can see a changing behavior of all people, mobility and others. We have seen that the working behavior, home office are increasing. It's an independent work, it's a mobile work. Migration behavior is also changing by the pandemic. We see a trend towards second homes, second residences, and we see a change in leisure and travel behavior. What is the initial situation from a regional and local perspective? We see a digitalization of all areas of life and structure. We see a high dynamic in many economic and social areas, aging, shortage of skilled workers, and these are some challenges for regions, for example, the creation of equal living conditions, safeguarding services, increasing the attractiveness of regions, and the maintenance of local care structures. What is the initial situation in the German healthcare sector? I think perhaps it's a little different between the European countries, but I would like to refer to the German situation. We have, first of all, the ambulant medical supply with medical practices, with a doctor. The closure of practices is a problem in the medical services. There are one doctor or several doctors. Several doctors would be, we call it medizinisches Versorgungszentrum, medical care centers, where a team of doctors are working together. And third system of medical supply, of medical services, is the medical practices in a network. Especially young medicines and young doctors want to work in networks. Beside the practices of doctors, we know in Germany the public or private medical care with hospitals with different levels. We have university hospitals with a maximum of care. We have hospitals of regular care, and we have hospitals of primary care. These are, for example, hospitals in counties. Then we have different types of sponsorships. We have also small municipal hospitals and district clinics, and we have privately run clinics. They are mostly specialized in 2 or 3 areas, cardiology, orthopedics, and something. Is it perhaps possible to switch off the sound? Everybody should prove whether the sound is switched off. Okay, and then after the practices and the hospitals, there are rehab clinics and medical services with private rehabilitation, and also the pharmacies and the medical health services, physiotherapies, and nursing services. The general medical care, especially in rural areas. The problem is that in the future, 10,000s of doctors will miss. They are retiring, or they are going to work abroad or something else. So we have a missing number of family doctors. We need, the policymakers need to make sure that the medical services will be delivered also in the future. The local decision makers need to develop a set of measures to influence the location decisions of young doctors. Doctors must be encouraged to work in rural, especially in rural areas. Perhaps is it possible to switch off the sound? Someone has the sound on. What are the decision criteria of doctors for practice location? There's the services of leisure, the necessity to do services by night or on the weekends. In Germany, we have private, we have patients with private insurance. So the numbers of private insurances are very interesting. Near to the hospitals and so on. These are all criteria for doctors for practice locations. What is now the digital ambulatory medical services of general interest? What are the target group? The target group are the baby boomers. I mentioned that it was our baby boomers between born between 1955 to 1965, 1970. They normally have a good education, they have a good income situation, they show a high mobility, and they have a high health awareness to nutrition, regular precautions, and others. What's the regional perspective? The baby boomers are normally encouraged perhaps to leave rural areas. They have a very different migration, and that's very important. 90% want to live at home until they die. And so the question is that they must have an access to medical services. What are the theses to this topic? The group of baby boomers exhibits specific behaviors compared to other population. Second thesis is due to the high level of mobility of the baby boomers, digital forms of provision are becoming more and more important. A third thesis is that digital services in the field of health is determined to residential behavior. So the baby boomers look for residences with a factor where is the health service provided. Here you have a map about the percentage of 50 to 60-year-old population by district in Germany. It's 2016, and you will see that here in the northern east part of Germany, there's a high percentage of this population group, but also in the western parts, and here in Saxony, in the North Bavaria, and in the border region to the Czech Republic, there's also high percentages of this group, and I think we should have a look to the medical services, especially in these areas. What are the questions to this topic? We should ask what is the role of general medical care for the baby boomer generation? A second question could be, what role does medical care play in the residential behavior of the baby boomer generation? And the third one is, which acceptance of digital forms of medical care exists among the baby boomer generation? Can the quality and the accessibility of healthcare be improved by including telemedicine services? Other questions could be that what system criteria are used to locate doctors? That's the question of supply side issues. What is the relevance of medical care infrastructure for municipal development, and what are the possibilities for influencing the location of medical care services, doctors, nursing facilities, municipal and private clinics? What are the steps to analyze these patterns? First of all, we have to analyze the importance of outpatients, semi-digital and digital medical services, the analysis of patterns for the location selection of physicians, to analyze the readiness to accept semi-digital and digital medical services by doctors, but also to have a look on the acceptance of the use of semi-digital medical services by the baby boomers. And we should ask what can be the support of local authorities for the location selection of doctors and baby boomers. We did, or in the next slides, I want to show you some examples for digitalization, the healthcare sector. The example of Upper Franconia. Upper Franconia is this region here north of Nuremberg, that's northern Bavaria. And I would like to give you some impressions about the digital services of e-health services. The initial situation is the old age of family doctors. I showed you at the map, the practice closures, absence of succession arrangements, long waiting times for a doctor's appointment, and new general medical care in case of change of residence. We did the project Society 4.0 e-health in rural areas. With this project, we want to show whether it could be an acceptance to digital health by the doctors, but also by the population groups, especially by the elderly people. And here you can see the healthcare 4.0 between the patient and the doctor, and you have an online appointment between the patients and the doctor. What are the advantages for the user? You are time independent. You can give a message to your doctor in the night or in the evening. Very independent of practice times of a doctor. You can save time. Also, the doctor can save time. Time saving by eliminating travel time. You must not go to the doctor. You can do it from your home office. And you have a video consultation, and perhaps you can save costs. Here are the partners of the e-health project, and the general benefits are the use of the same digital solution in patients and outpatients care, the use of one software, the use of independent of large players, and the usability optimized and download options in the app. You have an app. And now you may see that there is a digital healthcare platform between the services, between the patient, between the doctors, the clinics, and also between the patients. Here also you can see it in the slides which will be published. Additional to this e-health system, you can add a mobility application, a patient pass or a senior pass directly bookable from digital e-health application. This could be an additional advantage. You can also have a delivery service, for example, with the counties and with some suppliers like Edeka or Lidl or others. And you can have further applications on the app, for example, e-government applications, travel grants, transport of sick people, services provided by health offices, or you can also public transport plans, municipal platforms, and so on. Another further measure could be the ambient assisted living, the AAL information platform. Fraunhofer Institute is working on this platform. Last but not least, you can have a digital interface management with other services, care software, software for doctors, and so on. And what are the project results, and especially the benefits? I think this project helps to improve services of general interest through the use of digital solutions. Second, there's the possibility to diminuate to easy distance crossing through the digital applications. You have an efficiency increase, and you have networking to other partners, mobility partners, local care partners, e-government partners. We think that this project creates a high efficiency, a high user friendliness, and creates an access to a lot of services of interest. So you may see that the project is linked to healthcare, or between healthcare providers, mobility, local care, and e-government, and so a lot of partners are involved in the health service 4.0 or 4.1. So this is the short input for our workshop. Thank you very much for your attention. And I think we should go to Hannah Bock-Koltschin. She is manager of healthcare and social institutions, and she has prepared also a presentation. And I will stop my presentation. And Hannah, I would like to give you the word and would like to encourage you to give your report.
Thank you, Gabi. Can you see my screen?
Yeah.
Okay. So just to tell you what I'm referring to today is how to overcome obstacles in the development of e-health. So for those not knowing who I am, I'm a specialist and entrepreneur in digital health and future digital health ecosystems. I'm working all over the world, so I'm working with the most digitalized houses and the old dinosaurs, but I have a very special heart and passion for Alpine regions. And in 2017, my team and I developed a European unique digital healthcare ecosystem in an elderly home in Canton of Valais in Switzerland, which is modular based and scalable from one elderly home to the whole Alpine region in Switzerland. So it is not only limited to elderly homes, but you can use every e-health services on it. So when we talk about how today, we have also to think about the today's situation in the Alps. And for this, I want to do it on a very simple and easy example. Can you imagine that Granny Edna, who is living in the Alps, doesn't have the same quality of medical care in an emergency than someone living in a valley? I think you will agree when I say in an emergency, every second might be vital for all who need it. But today we are faced by three cases. The first, Gabi said it, is the lack of medical staff. The second is the lack of implementation of accessibility in this area, or mostly in states, even if the UN Charter is ratified. The third is lack of innovative thinking in how to solve it. So as I said, I worked in the past with a lot of states and organizations, such as from Estonia, which are the most digitalized in this field, but also with the old dinosaurs, which I called it, so the old European states, but also my home country, Switzerland. So during all that time, I learned a lot about the different developments of e-health, and to understand why some countries are successful and some not, we have to think about the digital sovereignty and the digital mindset of society and its state first. I will often ask during all my work, like phrases like the doctors don't want to change, or older people are not able to use digital tools. I can tell you that the oldest man using my digital tool is 105 years old. So I started with 103, so it is possible to do that if you want. So for me, to come over obstacles in that question is not only a technical question. For more, it is a question of how to implement a digital mindset in a society, in a government, and shortly in daily business. I could discuss endless with you how to implement this, but regarding our time space today, I would like to present you my 5 simple principles of success in startup a digital healthcare ecosystem. So the first is develop a strong digital sovereignty. The second is whoever and wherever you are in an emergency, every second might be vital. If you develop an e-health system, never forget that. The third is the once only principle. And the fourth is an individual is the owner of his/her collected data. And the second is build an e-government of trust. So let us take a deeper look into that. The first principle, develop a strong digital sovereignty in a world of e-health, means being able to act and decide independently, self-determinedly, and savvily in a digital healthcare ecosystem. So in fact, you need to think digital in context of healthcare, which is honestly not always easy, and having the courage to breaking down the barriers, which are too often not only an infrastructure problem, as we know, but a governmental made one. It means also that all users, builders, and deciders of an e-health system must learn how to think and act in complex terms and before they start with it. It means also to understand that e-health is only one package of services of a digital ecosystem. So if I'm talking about digital healthcare ecosystems, I mean just a package of a service in a whole global system, not only a state one. This ecosystem has the flexibility to work in an organization, in a region, in a state, or cross-border and without barriers. It means also to change from microcosmos thinking to a multiple flexible macro and global thinking. The second is, however, whoever and wherever you are in an emergency, every second might be vital. What I mean with that? So I mean, in fact, 2 points. The first is the accessibility, and the second is that a lack of something is a chance for successful innovation. But let us come to the accessibility first. Accessibility means that people with a disability have a right to use an e-health system, especially when UN Code is ratified and implemented a state law. So that means also from the beginning of the requirements, you need to think about that and you need to follow this. What does it mean for technical reasons? If you build a system by design accessible, you also profit from planning discussions like we have made it always with PDF and copy paste and analog and manual. So it helps a lot if you develop an e-health system. Also, you profit at least from having a great data quality and base for analytics. So often you make good examples. On this point, I want to do especially a bad example on how you don't do it better. So I live in Switzerland, and we have also a patient record system, which is very often discussed in good and bad parts. So it's called EPD. The EPD is not accessible by design and requirements, especially from the beginning. There are several technical solutions which are used in different cantons, and only a few of them are accessible proved, but not all are accessible. So on the other hand, a lot of hospitals here are today not accessible in e-health, especially not for blind people or deaf people. So they still use paper and sometimes handwritten. There is no application for sign language and so on. So there is a lot of potential to do it in a very easy and low-cost level better. So let us come to the second point. There's a lack of. Today, the healthcare and social institution system are focused on organizations. So with the long distance between patients and service providers, the e-health can offer even a greater benefit, especially to rural areas. So we have a lack of nurses, doctors, IT engineers. A solution can be the use of a scalable model. And especially with the IT tools. They are very expensive, and as we know, in Switzerland, we have in the Alps elderly homes with only 12 beds. So from the cost side and economics, this is a huge question, but I don't want that a granny from the Alps has to live in a valley just because of that fact. So what I did in 2017 was I had a Swiss elderly home in the canton of Valais, and I installed their renewable system with a real-time process optimization system and combining. So it is possible to use this elderly home as an IT base for such a 12-bed house in the Alps, for example, and to work together. So you can also extend it with a mobile home care service, for example, or to use the tools together with a GP. By using tools together, you have two good points. The one is you have a strong IT team which you can finance, which is often a problem, especially in elderly homes, not so much in hospitals. And you can giving elderly people the liberty to decide where they want to live, support jobs in the Alps, such as nurses, but also, which is very important, the suppliers of all these organizations, like farmers. So this is one important thing, but the most important rule for developing e-health is the principle 3. It is a once only principle. It is the most powerful rule in a digital ecosystem, and it helps with breaking down barriers and working cross-border. It is still used in some EU states, not only in one, like Estonia, but I know from several others as well. It is the key to success of your whole structure of the data collection, and this is the main issue if you develop e-health systems. Stop the copy-paste logic. So it defines that services can ask a responsible service for giving access to the data, such as names for showing in a document, but never copying and maintaining data. This is a huge difference if we talk about data and maintaining. It defines what information is collected and which public service is responsible for maintaining the data, and it guarantees that all necessary informations are up to date. And it protects against avoiding centralization of data and duplication of data. So you have a high quality databases, in fact, and this is the key to success, to exchange data in between different healthcare systems. So if we see that European regions, today we profit from working together, especially if I see in Switzerland, Graubünden, and then Italy, they work very close together. But we would profit doubly so when they can exchange data digitally, especially in an emergency, very easily. So let me explain all this, how it works in a very easy way. When I married, I got a double name. This is in Switzerland quite for a big problem, because they have it not so with double names. They cut a lot of times my name off and in half pieces. So I had to correct a lot of times the data from the government, from public service, which I have to refer even if I have a passport where it is written my double name on it. When I was in Estonia, because I'm as well an Estonian e-resident, I only informed one public services and not 5. So the one is who is responsible for my name. When I'm now ill and in Estonia and I go to my practitioner, he exactly knows my new name. Because of my EID, there is one registry, and this is up to date. Fourth is an individual is the owner of his/her collected data. So if we take the example of that, I am in Estonia and having to go to my doctor, I don't want that he has the right to see all my healthcare data. So I can ban him from my last blood analysis, for example. They got a list of all my documents and see I have access or I don't have access. And they can ask me if I have banned my doctor from it, if they can have access or not. But it's me who decided it. And it's also me who decide who or can ask better for the reason why someone was looking my data. So for example, if it was my practitioner in my e-health system, that's okay. But if it was the police, I am really asking why the police is looking my e-health data. So, and I can ask officially the public service why you have an interest, and if they don't have, they got in a very trouble. So what does it mean? A very key role plays here at transparency, because you need to trust the system and to avoid fraud. And the power of a user to decide about the data is also very important, because then if you use a tool and then you're developing your digital sovereignty and you work on this and you get more close to this and you learn so much about, and then it is not the digital enemy anymore, but it is your helping friend. Because if we build an e-government of trust, that's very important. And can you imagine that an Estonian or an e-resident didn't see a public service for years or doing taxes less than 10 minutes, just from the sofa, by the way? And can you imagine if you have a contract, if you can sign a contract with an EID legally, binding both in Estonia or in your country and the European Union? And can you imagine that you go to a nurse in the Alps and just for getting your prescription, and that the doctor's working in a virtual office, mostly by tablet with you? So this happens when you do not digitalize your today bureaucracy as it is, and starting being innovative and giving more power to the profession of a nurse and use her as a key role of local work. Such systems in the Alps means for me to live independently, having better access to care, especially when you have chronic diseases and just need a prescription. And on the top, the bureaucracy will cost less, which I think we all love because we have to pay insurance, right? Such systems are not a future discussions. They still exist, especially in Scandinavians, and Estonia, but also in the efforts we made in the Alpine regions from the projects in the last years. So let us think what you need to do. You have to agree, especially as a government, on a few strong common principles on how to redesign rules and procedures. So you need to stop unnecessary data collection and task applications and becoming open and transparent. That sounds simple, but yes, in theory it is. But the challenge is changing a government to a strong digital mindset. So, by the way, if anyone wants to use a digital ecosystem, you have to educate them first. And then they learn quickly how it works and get a better digital mindset of how to use such things and how to think about. Which is also an important question, cybersecurity. So cybersecurity, in my opinion, should be by the state, and also you need a digital backup in a special embassy, for example, out of your country, because there is a possible of physical attack. And last but not least, which is important for me, is if you make e-health development as a state or a bigger region, please don't do it as the first service. It will never work, because there are so many other questions on it. For me, it is one of the latest services you should implement. First, basics, and then the complicated processes is my vision. Starting being innovative and giving more power to the profession of a nurse and use her as a key role of a local work. So this is quite very important. If you develop e-health, it's not only IT and technical, it's not only the government, but it's also thinking about the professions which we have today. Are they on a point which they have enough power, or should we give them some new power? And especially in medical care, they are not too stupid to do. They need just an education in some things, and then they could also do this. So this would also help to get over the lack of GPs. So I just want to say thank you. And for me, innovations are a precursor to future living conditions.
Anna, thank you very much for your very interesting report and the very interesting slides. I think it's a new view on data, on cyberspaces and so on. I think that's a very important topic to our workshop. Perhaps we should collect the questions after all reports, if you agree to this, or are there special questions to Hannah? I think perhaps we should go to our next report. Mauro will give us a report about how digitalization helps to improve the access to health services. Mauro Grigioni is head of the Italian National Center for Innovative Technologies in Public Health. And Mauro, perhaps you can share your slides, and I will give you the word.
Thank you. I need to find my slide. Only a moment, please.
No problem.
Yeah.
I think the technical support could also help.
No, I suppose that this is my problem with the screen, but I solve very briefly.
Oh yeah, no problem.
Okay, excuse me, but
wonderful, thank you.
I suppose you can see me.
Yeah, okay.
Okay, I wish to thank first for your kind invitation to this meeting. It's the second time I am with you, and as a director of this kind of center, I wish to put some attention on the technologies. In effect, the question I have from you are these: how to improve the accessibility to health service. Generally, people talk about telemedicine in a general sense, but telemedicine is only one passage of a more complex process to share information and something that is a technology, that is the data. I wish to give you some example, but I wish to start from the organization of Italy. As you know, we have 20 regions, and each region has its own local organization for the health system, and the same is from the point of view of data storage and data use. And this generally creates some problems. As you know, our health dossier of the people is not completely interoperable within the regions, and not only cross-border. MisMi are working very hard with us in the ISS to do a better situation from this point of view, especially from the point of view of code for the data within the health dossier, but also from the point of view of structure of the data. I wish to give you a different model. In effect, during the pandemic, as you know, several regions suffer from the pandemic more than other one. Some people say most probably the hospital-centered model is not so good, or the information were not shared, and so on. In effect, several variables are affecting this kind of results. But from the point of view of the main technology of the moment, I suppose that the data are, and also Anna talked about that, the data, the sharing is really the first level of possibility to improve access to the health system. I am showing now a sketch from Kinz and Topol about the possibility to use big data. What is big data? Unstructured data. Data with different format, with different value that could be put together. They comes from who? From the patient generally. And today we collect data for any, for very a great number of platforms that could be from health and not from health. As you know, Facebook, Google, and so on. Okay, the data from the point of view of health, of wellness, in effect could be bring from us to, by means of the smartphone as an example. Where this data go? This data must be collected, but not only collected and stored. They must be used to extract information about our situation in lifestyle, well-being, health, condition, and so on. Then you can build a knowledge base. This knowledge base could be the recipe for new intervention, for more personalized intervention. This was the idea of Kinz and Topol, but we are not doing so in effect. The technologies at the moment are working for us. Most probably this is the final action from the point of view of chip manufacturer. Most probably we will have edge computing with artificial intelligence within our smartphone. Thus, most probably, our physical data, vital parameters, and so on, will be analyzed on our smartphone before to send information to the big data recipe. Thus, also the privacy situation could change in our favor from this point of view, because the original data remains on our hands. This will be common to the health system and to the commercial system. And this is the close future, and European Community is working on that. Thus, the AI chips will be one of the actions that help us to are able to give more information on our well-being, on our lifestyle, and so on. The other point is to have a completely covered nation from the point of view of the 5G. This is relevant because during pandemic, many people cannot be connected, especially not only from their personal talent in digitalization, but also from the point of view of the infrastructure that did not reach, excuse me, all the people in the nation. The other problem is that technologies innovation is doing well with the medical devices, but the information from those medical devices, also the active implantable medical devices, must be considered for the ownership, because generally those data are in the ownership of manufacturer, not of the patients. And this is one point about the power of patients discussed by Anna. Another point of view is the real interoperability. This is a problem of standardization, of protocols, of the semantics, of codings. Then the data quality. We know that the ISO guideline state several principles about data quality, but they are not used in our exchange in ICT telecommunication technologies. And this is a problem at the basis of the technology. Thus, if we wish to collect and build really a digital ecosystem, we must face with all this kind of point to be be set. Not only technology, but the protocol, the standardization to use those data, those technologies. Okay. If I go to the web, I can know something about the actual innovation from several websites similar to the Gartner website. All the technologies at the moment are considered the connectivity, the capability to interact with the patient. And you know, in Italy, we have some new decree about televisit, teleconsultation, and so on. And the capability to exchange the health information. These are on the right side of this kind of hype cycle. That is the only part that is at the level of the productivity, at the level of the market. All the other things are again in the face of, in the side of the funding, and thus they are not on the market. Excuse me. What the technologies on the market in Italy, this is what I found analyzing all the technologies offered to the Ministry of Digital Innovation during the first call in February. And as you can see, we have again too much electronic medical record that are vendor locked, many data and information security tools, the cloud support for IT, but also the real-time geofence systems. This is a real, a useful paradigm for me, especially when you have a region that you must network. Okay, thus I go further to show you some example. But what we have learned from the difficulties of our nation, we need to have the access to the data. We need to have this access in real time. We need to have measurement technologies and to have all the support from the point of view of platform, app, clouds, and so on. Okay, this is a first paradigm that is typical of one region. Many regions use this kind of IT paradigm. We have the region staff on the high level, then we have the local agency staff, and finally we have the territory, the staff from general practices and the hospital specialists as a territorial level. You see me in the televisit dashboard for the general practitioner, my general practitioner. Okay, all these three levels share the same data between them, but with different credentials. At the level of at the first level, the level of the general practitioner with my face, you have the real data measured on the patient. The triage, the COVID triage obliged by our law. At the second level, the intermediate level, you can have automatically a great part of the contact tracing activities. Thus, you leave to the app to trace only the asymptomatic people that you cannot trace thanks to the local visit, to the televisit, and so on, to the symptomatic activity. The final level is the level of the planning, of the strategic planning. Then at the region staff level, you can decide which kind of people and where you must control or to test to know the infected people and so on. You can also control the motion, the mobile, thanks to the SIM card from the cell phone, and so on. That this is an organization that is parallel to the actual health system in the region. A similar system was built by me and other colleagues all over the nation, all over Italy, in the case of the environmental surveillance, because we think to help our epidemiologists and to prevent outbreaks, substantially by monitoring the wastewater, the sewage plants. As you can see the nation with all the plant indicated in this dashboard. This is the dashboard with which I can control who is delivering information about the sampling of wastewater in its own region. And as you can see, we have 82 centers and 142 sampling sites. At the sampling site, we have one app that has helped the operators to give us directly in real time the sample. On the 82 centers, we can have the laboratory measurement on that sample, and thus we can make a new dashboard with a qualitative ongoing of the infection, where you can see the red line. You have detected the virus. Where you have the green line, obviously no. From this point of view, you can have a quantitative real-time information about which plants and at the same time which population is under a strong infection, and you can go to the plants and select people, and you can have the possibility to test them. We are also working on the quantitative analysis. These are the number of copies of the RNA of the viruses obtained by the real-time PCR, and you can understand from the data what happened in terms of correlation between wastewater quantitative results and the number of people infected, the number of people hospitalized, and the number of intensive care units occupied. At this level, we are analyzing this kind of situation in real time. We are trying to obtain an algorithm to follow the outbreaks. This paradigm is relevant for me because this is the sharing of information, the capability to motivate professionals, and if you can give some information by this way, you can also motivate people to participate in their own health care. Substantially, a sort of self-management, of self-empowerment also. From this point of view, one issue that I am stressing with my colleagues in several meetings is that we must use a distributed system and a federated database, such as we can obtain from this kind of models, in effect, the possibility to don't have silos, don't have a strong collection of data in one point, because this is not good from the point of view of cybersecurity, but and also from the point of view of who has the power to decide what I do with the data. But I can have the learning of many artificial intelligence algorithms, and in the same time we can search for a particular molecule to treat a patient with rare disease, as an example. The final point I wish to stress is the open data possibilities. The European Commission asked to all the countries in Europe to participate in the building of a data portal, in European COVID-19 data portal, and also to prepare a mirror for each nation. This is the mirror data portal for Italy, for open data, and we were capable to put some dashboard from Protezione Civile, some dashboard about images, especially radiological images, genomics, and epidemiological data. And this is another instrument, another tool to share data, to share information, and to motivate people to follow their own health in an appropriate way by means of the digitalization. thank you for the possibility to have talked with you. And I suppose that the digital ecosystem could be a solution if you are able to make a network between a strong connected community using a network platform with the sharing of information, the capability to provide new information by means of analytics. Artificial intelligence is one of them. And in the future, I suppose we can have digital twins as a very strong tool to control the situation, a local situation, giving a feedback to the system. Thank you. Thank you again.
Oh, thank you very much for the interesting report, especially the reference to the pandemic and pandemic situation. Thank you. I have a look. Yes, to the chat. Our technical support tells us that the workshop closure times is at 4:45 o'clock. But I think yes, we started a little later, and so I think we should have our next report of Marco Bazzani. Perhaps you will, I give you a word, I don't want to say something. You will give us an overview about an integrated health model for an inclusive mountain. Please give us your report, and the slides are here. Thank you.
Okay, thanks very much. Thanks very much to Thomas Eger for organizing the conference, and you, Gabi, for moderating the session. Thanks for the other colleagues on this session. I would like to get the inputs highlighted by Anna and Mauro, and try to show you how these inputs are solved in a MisMi project, and how to reach some results about the result of this project, about the inclusion, the social inclusion of mountains and the people lives in mountains. I'm Marco Bazzani, and I work in Links Foundation, and I'm very glad to present the result of MisMi project on behalf of our coordinators of the project, Anna Castiglion and Elisa Pasini from House Valle d'Aosta. MisMi is our project, a new integrated model for health, for try to include social and health, include the mountains regions. For doing this, we should need a new organization models for tracking and keeping this idea. So we would like to change the paradigm of view and thinking about social and health services such as care and prevention, but start in a place of life instead of a place of illness. And for doing this, we need new innovative systems and new innovative services for performing this vision. So with MisMi, we create a new supporting professional categories such as the family and community nurses and the community animators, and also we try to use technologies. In this way, technologies is not the output of the project, but is only the enabler of this change of mentality. This is some figures about our project. As you can see, is an Interreg Alcotra project. So this cross-border cooperation program between Italy and France. Especially for Italy, it was involved the Valle d'Aosta region with the two districts, District 1 and District 2, and the Tarentaise region from France. As I said before, MisMi created two big outputs. One is new professionals, and this is about the social care and the healthcare, and these are named the community animators that aims to facilitate access to services and to take care of emergency in a very quickly way to respond to it and share information and cooperation between the health system and the social system. Furthermore, in the Italian side, we tested and we used new professionals, the family nurses that can help to manage the health of people in terms of prevention, in terms of care, in terms of use of telemedicine technology systems. About telemedicine, as highlighted by Mauro, especially in Italy, we have a different type of telemedicine, from telemonitoring, teleassistance, and in MisMi also telephysiotherapy. So the idea is to use ICT for maintaining the same quality of service of presence, but these services are taken by remote, by technologies and people by remote. For the France side, in Tarentaise regions, we tested two different type of telemedicine system, teleassistance and telemonitoring. You can see in the picture that there is this quite big desk in the nursing home or directly at home of people that help to connect the health professional in remote to the seniors, to the elderly in their home and their home nursing home. Especially we also with the help of some professional or informal caregiver, parents, sorry, relatives or the nursing at their home. The idea is to keep track of monitoring data and to perform some televisit directly by the remote through the technologies. In Italy, we test another type of technologies, telemedicine technologies. It is telephysiotherapy, where at the home of people, a technology system has been installed in order to monitor the result of the performance of physical exercises, especially for shoulder pathologies. The idea is that at the home, in the place of life, people can perform exercise, also watching TV and watching their movement through an avatar. And in the background, and perhaps also in terms of time, the health professional can monitor the performance of the user, can change the exercise, the therapies can adjust and suggest the way to improve the movement, improve the exercises. Finally, there are a lot of projects in telemedicine and a lot of ideas, but with MisMi, we try also to understand if they are sustainable for sustainable in future. And so we perform an economic evaluation by considering a cost-benefit analysis, considering all the categories of people involved and the benefit, the advantages, the losses generated by MisMi, and comparing this result also with a situation as is without MisMi. Well, two things are important. One is that we definitely demonstrated that this type of services expressed by MisMi is sustainable because we can reduce cost in performing the activities and in maintaining healthy the population. And the second thing is that through a quality questionnaire, so considering the quality of life and the expectancy of life, we see that the people involved in this field trials of MisMi appreciate the new way to care and to take care by the health national system about their care. So to sum up, some weaknesses, and I would like to change this point of view to opportunities. I would like to sum up some lessons learned before closing my intervention. One important thing is, as highlighted by Anna also, is the user-centered design. So we don't have the idea to put technologies from top-down level, but we have to engagement the end user in terms of patient, in terms of nurses, in terms of health professional, in terms of public administration, and whatever performs health services in our regions. The second thing is that ICTs, so the technologies enable the changes. They are enabler, not are the changes, but also vice versa. If we create a new process, a new service model, a new idea of service model, then the technologies can follow this change of view. Of course, a close interaction between the different stakeholders from the patient, from the hospitals, from rehabilitation centers. And finally, this is an important thing I think is that physicians and nursing, so health professionals, talk totally different languages by engineers. So one of the things that I think I consider very important for implementing telemedicine system that have a good result is try to have a common language between all the stakeholders in order to understand really which are the problem, gathering the user needs, and then propose the real and the right solution for everyone. Finally, you can see that we try to investigate about the cost analysis, and we think that in 6 years, so 3 years after the close of the project, we can earn about 2 million euros by using MisMi systems in terms of technology, in terms of professional, and also an increase of benefit in such figures. So I think very, very good results. My presentation is finished. Thanks again for your attention, and I give again the floor to the moderator and to Gabi. Thank you.
Yeah, thank you very much, Marco, for your report. It was, I think, very interesting session and workshop, and the technical support told me now in the chat that there are 2 minutes for a plenary, and I'm not sure what now we have to do. I think perhaps we should wait, and we can have 1 or 2 questions, but I'm not sure whether they give us the access to the plenary. The technical support is shown. Yes, I think we should go to a plenary session.
Okay, so we switch to the plenary session.
I think.
Thank you.
Okay, you auditorium should switch to the plenary session. And I think we can stay in this Zoom link.
I think you have to stay as at the beginning, so they can show your face and the parallel session of the workshops.
Yeah, I think we should stay here. Yeah. A lot of participants are
Io
in
ti
this
sento,
workshop.
sì.
I think they should change.